distinguished guests, fellow citizens, as we gather here today under the theme Down Memory Lane, from 1993 to present, we embark on a journey of reflection and analysis that resonates deeply with the heart of our nation. Our focus is none other than Ghana's democracy and its consequential impact on one of the fundamental aspects of our society, public health. In 1993, Ghana made a significant transition towards democracy, marking a pivotal moment in our history. As we stand here in the present, it's only fitting that we delve into an angle of great importance. Has Ghana's democracy delivered a health dividend for its people? It is with a sense of duty and an inquisitive spirit that we address this question, delving into the intricacies of life expectancy, maternal mortality, infant mortality, and the 5 mortality, and the crucial measure of survival to the age of 65 years. Life expectancy, a barometer of a nation's overall health and well-being, serves as an essential landmark in our analysis. Over the past 3 decades, have Ghanaians experienced an increase in their life expectancy? What tale does the statistic tell about the quality of healthcare, education, and social welfare in our democratic journey? And how does this trajectory compare to nations with similar gross domestic product levels? Maternal mortality, a sobering indicator of a health system's capacity to protect and preserve the lives of mothers during childbirth, demands our attention. Has Ghana's democracy translated into a reduction in maternal mortality rates, ensuring that women can bring life into this world without facing unnecessary risk? And once again, how do our experiences align with those of our economic counterparts? Infant mortality and under 5 mortality rates stand as a stark reminder of the fragility of life and in its earlier stages. These measures encapsulate the effectiveness of healthcare interventions, nutrition, the social support system, in securing a thriving start to our youngest citizens. Have the democratic changes ushered in during the past 3 decades translated into tangible improvements in these critical aspects? And how do our figures stack up against the countries with similar economic profiles? Lastly, survival to the age of 65 years, a milestone that signifies the attainment of seniority, carries deep implications from the overall vitality of a nation's populace. Does Ghana's democratic era ensure that our citizens are living longer, healthier lives, thereby contributing to a robust, productive society? Can we as a nation proudly state that we are safeguarding the well-being of our elders? To answer these questions, we must embark on a journey of data, analysis, and comparison. We must engage with the nuance of policy decisions, resource allocation, and the intricate tapestry of socioeconomic dynamics. In our pursuit of understanding, we would find ourselves exploring the landscape of public health and governance, seeking the nexus where the two intersect for the betterment of our society. As we unfold the pages of Ghana's democratic history, we do so not as observers, but as participants in a collective endeavor. Our examination of health indicators is an acknowledgement of our duty to ensure that the democratic dividend reaches every Ghanaian, from the youngest to the oldest, from the most vulnerable to the most prosperous. In this commitment to fostering a nation where the well-being of our people is the cornerstone of our progress. Ladies and gentlemen, the road ahead is illuminated by lessons of our past. It is through these lessons that we can shape a future where our democracy not only endures but thrives in its mission to bring prosperity, dignity, and good health to all Ghanaians. As we delve into this journey from 1993 to the present, let's embark with open minds, willing hearts, and an unyielding dedication to the betterment of our great nation. I need to give some opening credits. We cannot go through this exercise without looking back at what our founding fathers thought of healthcare and what their expectations were for Ghanaians. Kwame Nkrumah, the first president of Ghana, possessed a profound and holistic perspective of the healthcare system he envisaged for his nation and the broader African continent. His views, expressed during his tenure from 1957 to 1966, continue to reverberate as a testament to the commitment to the well-being of his people. The framework of healthcare delivery set up post-independence has by and large not changed much to this day. For example, the chaos of outpatient departments remains even in an era where computing allows for better organization of human traffic. Nkrumah's philosophy was rooted in the belief that access to quality healthcare was not merely a privilege, but a fundamental human right. He declared in a speech to Parliament in 1961 that it is not enough to have a healthy population, but we must also have a population with the right mentality. And I'll repeat that. It is not enough to have a healthy population, we must also have a population with the right mentality. With this in mind, he embarked on an ambitious mission to build a comprehensive healthcare infrastructure, investing in medical facilities, training programs, and disease prevention. His profound understanding of the interplay between healthcare and development led to the establishment of institutions like the University of Ghana Medical School and the Medical and Dental Council. Nkrumah's vision extended beyond Ghana's borders as he recognized the importance of collaborative efforts in addressing health challenges across Africa. He stated in an address to the Organization of African Unity in May 1963 that Ghana's well-being and health cannot be separated from the well-being and health of the African continent as a whole. Nkrumah's legacy as a pioneer of public health remains an inspiration, reminding us that a healthy society is the cornerstone of a progressive and prosperous society. His vision continues to guide us as we strive for a comprehensive health care, not only in Ghana, but across the African continent. 66 years after independence and 3 decades into the Fourth Republic, are we reaping the dividends of the vision of our first president? Should Asajifo reincarnate today, will he be proud of the quality of healthcare Ghanaians receive? When I was asked to deliver this lecture, I reflected on the timing and the fact that my father, a man whose achievements I can hardly light a candle to, was yet to be laid to rest. I would have wished that the circumstances would be different. So I set to ask myself, what would Daddy have advised? It immediately dawned on me that the academic, known for his lack of political correctness, would have said, "Son, go and speak out. Be candid and factual, but hold no punches back. I will bear this in mind as we go along, so forgive me if I touch a few nerves and step on a few toes. I mean no harm. We are at a point where we either taste not or drink deep. In August 2015, my mother passed away. The previous year, she had been diagnosed with endometrial cancer. Initially, the plan was to fly her abroad to seek health care. But as fate would have it, other complications made long-distance flying impossible. We therefore had to deal with Ghana's health system firsthand in a quest to keep her alive. In that period, we became aware of the good, the bad, and the ugly aspects of healthcare provision in Ghana. It dawned on me, it dawned on us all that even having the option to fly abroad for care wasn't foolproof under certain medical circumstances. I told myself I had to be an advocate. Today, following the passing of our father, this quest is even stronger. I would also like to acknowledge the presence of my brothers, Kobna and Kofi. I pay special tribute to them, as we are all in mourning, but they have deemed it necessary to listen to me. To Kofi, a man I have debated and sparred with from my infancy, I say sorry if some of what I say rub you up the wrong side. Now let's look at the democratic relevance of health. In a democracy, health systems hold immense relevance as it serves as a tangible manifestation of a government's commitment to the well-being of its citizens. A functional health system provides equitable access to health services, irrespective of the socioeconomic background, ensuring that the principles of democracy, including equality and social justice, are upheld. Moreover, a healthy populace is more likely to be active participants in the democratic process, making informed choices and engaging in civic activities. Health dividends are acknowledged globally with a push to attain universal health coverage by 2030. Universal health coverage means that people have access to the full range of quality health services they need when and where they need them, without financial hardships. It covers the full continuum of essential services, from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course. This is in line with the United Nations Sustainable Development Goal 3, that is, ensuring healthy lives and promoting the well-being of all ages. The determination of whether a health system is yielding a democratic dividend for the electorate can be assessed through several indicators. One of such indicators is the accessibility to healthcare services. If citizens, regardless of their economic status, can easily access essential healthcare, it signifies the democratic principles of inclusivity and equal representation are being translated into action. Another crucial indicator is health outcomes, such as reductions in infant mortality, maternal mortality, and life expectancy improvements. When a health system is effectively addressing these indicators, it signals that the government is genuinely prioritizing the well-being of its citizens and creating an environment conducive to democratic participation. I must state here that my emphasis would be on our health and on our population's health outcomes. According to the World Health Organization, health outcomes measure a change in the health status of an individual or group which can be attributed to interventions. This suggests that to obtain significant health outcomes, a country must be purposeful and intentional and I'll return to this. In the African context, the relevance of a functioning health system is particularly pronounced due to persistent challenges like communicable diseases, inadequate healthcare infrastructure, and an unequal access to medical services. For instance, countries such as Rwanda have made remarkable strides and improved healthcare access and quality, resulting in positive health outcomes across their country. The implementation of community worker programs, which provide health services even in remote areas, has contributed to an increase in the democratic dividend by ensuring citizens' health needs are met. Therefore, it is not surprising that most governments tout investments in health. Often, they see the health sector as a vote generator. The question then becomes, do all the inputs they put in health yield the needed outputs that must be leveraged to achieve significant health outcomes? Our journey to answer these questions starts now. The key input of any health system after a democratic mandate has been given to a president is money. The easiest way to compare the funds allocated to healthcare is to determine how much money is invested per person per year, what is termed health expenditure per capita. Ghana's health expenditure per capita in 2022 was $84.94. This was an increase of 454% of the figure in the year 2000. In comparison, Rwanda increased its figure by 422% over the same period to their current $57.50. Over the same period, Liberia and Sudan increased their figure by 306% and 53.6% to United States dollars 52.09 and United States dollars 23.39 cents respectively. How do the health outcomes of these countries compare? The following selective health outcomes will perhaps give us an insight. Let's look at life expectancy. According to the World Bank document, World Population Prospects 2022, life expectancy at birth indicates the number of years a newborn infant would live if prevailing patterns of mortality at the time of its birth were to stay the same through its life. As said earlier, it is a barometer of a nation's overall health and well-being. In 1993, life expectancy in both Rwanda and Liberia was 42.17 years, while Sudan was 46.58 years. At the same time, life expectancy in Ghana was 56.42 years, well ahead of all three countries. By the year 2000, a child born in Rwanda was expected to live to 47.13 years, Liberia 51.36 years, and Sudan and Ghana 58.20 years. Therefore, 7 years after the commencement of our Fourth Republic, Sudan had increased the life expectancy of its citizens by 11.62 years, whilst Ghana had increased ours by 1.78 years. All three countries had shown better improvements in their citizens' health and well-being compared to Ghana. This had moved Ghana from 155th on the global ranking of 193 countries and states to 154th, and Sudan from 170th to 153rd. How did Sudan do this? And for that matter, Liberia and Rwanda achieved this with a lower health financial investment compared to Ghana. A look at life expectancy data for 2022 and comparing it to the figures in 2000 is even more intriguing. Rwanda surged ahead and improved the health and well-being of its citizens by 40.18%, moving life expectancy from 47.13 years to the current 66.07 years. Liberia had an improvement of 18.2%, Sudan 12.14%, and Ghana 9.60%. Looking at the health investment each country made per capita over the same period, how is it possible that Ghana had the highest improvement, 454%, but attained the lowest improvement in health and well-being of its citizens? Is this the democratic dividend in health the framers of our Fourth Republican Constitution envisaged? Now let's look at maternal mortality ratios. Maternal mortality ratio is the number of women who die during pregnancy and childbirth per 100,000 live births. It's an indicator of a health system's capacity to protect and preserve the lives of mothers during childbirth. For a democracy to deliver a health dividend, this right of women should be a priority. Again, let's see how Ghana has performed. Between the years 2000 and 2020, maternal mortality rates dropped by 47.3% in Ghana. In comparison, over the same period, Rwanda saw a fall of 72.12%, Sudan 57.94%, and Liberia 16.07%. Hence, apart from Liberia, the comparator countries saw a higher decrease in the risk women face during childbirth compared to Ghana, with less investments in health. Did our democracy promise a lower value for money to our wives at the outset? If not, can it be said to be yielding the right dividends for the Ghanaian? Now let's look at infant and under 5 mortality. Infant mortality rate is the number of infants dying before reaching 1 year of age per 1,000 live births in a given year. We can all accept that a democracy cannot be said to be yielding a health dividend if health outcomes are such that the most vulnerable are not protected. Is our democracy protecting the lives of our vulnerable toddlers? What do the numbers say? Between the year 2000 and 2020, the percentage decrease in infant mortality for the comparator countries was as follows. Ghana saw a decrease of 48.09%, Sudan 40.60%, Liberia 58.20%, and Rwanda 72.27%. Yet again, how is Rwanda achieving these significant health outcomes with less monetary input? Let's look at the probability per 1,000 that a newborn baby would die before reaching the age 5, if subject to the current age-specific mortality rates, termed under 5 mortality. Between 2000 and 2020, the risk of children dying by their 5th birthday was decreased by the following percentages. Rwanda by 78.73%, Liberia by 59.80%, Ghana by 56.08%, and Sudan by 54.90%. Yet again, with the highest percentage change in health input, Ghana did not achieve the best outcome. Now let's look at the percentage of our population above the age of 65 years. A high percentage of any population reaching age 65 or above indicates improvement in health deliveries in the health delivery system and an indication of better health outcomes. Moreover, a higher proportion of elderly citizens also suggests lower mortality rates among the younger age groups. From a governance standpoint, this matrix showcases the efficacy of policies relating to healthcare, social support, and economic stability. Countries that experience an increase in the percentage of their elderly population often demonstrate proactive governance, investment in health infrastructure, and policies promoting healthy aging. Based on the available data, between 2000 and 2020, Ghana increased the percentage of its population above 65 years by 6.89%, from 3.19% of the total population to 3.41%. Comparatively, Sudan saw an increase of 33.07%, Rwanda 29.17%, and Liberia 5.96%. It is clear, therefore, from the selected health outcome indicators that under this Fourth Republic, our health system has not delivered as much as it could based on the inputs successive governments have made in health. Under this democracy, our health system comparatively seems not to improve the longevity of our population as a whole, can't protect women adequately during childbirth, and is failing the most vulnerable, the very young. Now let's look at certain things that have happened under this democracy, what I call democratic health outrage. Then there is the forgotten populace who rely on traditional medicine, priests, fetish priests, juju men, malams, and outright quacks. Their percentage is not clearly defined, but is known to be significant. Whilst researching, I could not find any accurate statistic of their exact or approximate estimate. If anyone has this, could they kindly share? They are forgotten because, though there are merits in herbal medicine, we see many of these products being touted as cures for all sorts of ailments, some of which can only be managed but not cured. How in a democracy we can allow such reckless commentary about healthcare in clear violation of our laws, whilst these concoctions damage the liver, kidneys, and other organs, is just disgraceful. Unfortunately, when these organs are damaged, many who fall in this cohort lack the financial clout to access services such as kidney dialysis. Can this be said to be the positive health dividend emanating from our democracy? As a pharmacist, I am first to acknowledge that the origin of many orthodox medicines are from plants. I'm also aware of research done by leading lights such as Professor Kwame Sapong and Sir Samoa and Ayim, my mentor, into the efficacy of many plant extracts in Ghana. My call, therefore, is not a frown on herbal medicine, but a charge for further research and stricter regulation of the sector based on existing laws. After all, I'm inclined to believe we live in a democracy, not a banana republic. If you factor in that under this democracy, the country's central medical stores were destroyed by arsonists who till date have not been traced and prosecuted, the picture is opaque. Should we be happy with this performance? I doubt. Now let's look at health as a vote driver. Why then have politicians over the 3 decades managed to use slogans in health as a vote driver? Before I try to answer this question, let's look at our overall mortality rates as a population compared to the comparator countries. Between the years 2000 and 2020, Ghana decreased its crude death rate, the number of deaths occurring during the year per 1,000 population, by 23.72%. Sudan by 30.93%, Liberia by 43.60%, and Rwanda by 63.24%. This indicates that even though Ghana has had the highest increase in financial investments in health, we have shown the least improvement in the ability of our health system to keep the population alive. Is it any wonder that we have the slowest improvement in our life expectancy at birth? The truth is our politicians are very good storytellers and sloganeers. They are well aware that investments in health take a while to trickle down as health outcomes. For example, achieving significant improvement in infant mortality rates may take between 5 and 10 years. For life expectancy, it can take around 10 to 20 years. and for maternal mortality rates, it can take between 10 and 15 years. Therefore, they are clear that they cannot claim credit for most of these outcomes over a 4 or even 8-year term. However, if they build a hospital, CHIPS compound, or pay trainee nursing allowances, they could point to these at the next election, whether or not these are value for money investments or misplaced priorities. Being the storytellers they are, they opt for the tangibles and carve these stories around them. Hence, slogans like Agenda 111 have become catchphrases on which votes are procured. But then again, we are partly to blame. Is it not strange that in a country whose constitution speaks of the directive principles of state policy, we find a government commencing building of new health facilities when the previous facilities started by the previous government remain uncompleted? How have we as citizens become so divided and supine that we fail to stand up when things like this happen, knowing very well that the main driver of such schemes is procurement and sometimes sleaze? This is a major contributor to the waste we see in our health infrastructural projects, and perhaps a major contributor to why health inputs yield marginal outcomes. When they try to compare their performance in health, our politicians elect to compare with the performance of their opponents, not with the performance of countries with similar GDP or health expenditure per capita. So whilst they keep themselves busy, shouting themselves hoarse, as we look on, we slide down the global rankings of most health indicators, whilst countries like Rwanda rise rapidly. They behave as though we are in a race to the bottom. Yes, I would be the first to acknowledge that there have been improvements overall in most of our health outcomes in the last 3 decades. I also acknowledge that achievements such as Ghana's expanded program of immunization and guinea worm eradication, which led Ghana being declared free of the disease in 2015 by the WHO, are examples of what good looks like. To illustrate, the introduction of the National Health Insurance Scheme under the Kufuor administration was an excellent health opportunity. It was supposed to improve access to affordable health care through the minimization of out-of-pocket payments by ensuring access to health care is not constrained by the lack of funds at the point of use, a requirement for a country to attain universal health coverage. Thus, this, if achieved, should have led to significant improvements in outpatient per capita of this country. A look at the data published by the Ministry of Health suggests that since the introduction of the scheme, there has only been a marginal increase in outpatient per capita from 0.98 visits per person per year in 2002 to 1.13 visits in 2021. To put this in perspective, on average, this should be around 4 in a proactive health system. What it means is, on average, each citizen should visit a primary care clinician every 3 months. This should have led to early diagnosis of especially non-communicable diseases, improved prognosis through enhanced patient concordance, and ultimately, a better quality of life and life expectancy. Unfortunately, the data present suggests that though coverage has improved, the health outcomes expected has not occurred. Also, there is no evidence to suggest that all stakeholders know exactly what the NHIS is offering. A quick example is, do patients and carers know exactly what drugs are covered by the NHIS? Anecdotal evidence suggests that the information is not clear to septuagenarians and octogenarian patients. Already they are not much, and the few left don't know what's going on. If we are fortunate enough to achieve the length of life against the odds of the current life expectancy figures, would we know exactly how to access any dividends in monetary terms? Pause and think about this and ask yourself, what went wrong? It is disingenuous, therefore, for politicians to speak to absolute numbers and not comparative trends. The former approach, which is their preference, is the hallmark of mediocrity. Unfortunately, our gullibility as citizens prevents us from reading between the lines and challenging this approach. Sometimes, we even side as gladiators in the theater, defending the very things that affect our quality of life negatively. Who did this to us? I remember that a former president told that the Ghanaians had short memories. Then the one who criticized him for making that statement took over under the slogan, "We have the men." Seriously, does the data as presented tell us that these supposed men have behaved like knights in shining armor? I do not believe that if the framers of our Constitution were asked today, they would be proud of the circus our health system has become on the altar of political expediency. I reject any assertion that they would accept that these are our best dividends. These are the best dividends our health system can provide in a democracy. Now let's look at a few lessons. I've tried to limit the choices of comparator countries to Africa. I've done so because I'm not oblivious to the fact that often those who want us to continue down the trend of mediocrity frown on any comparison of our situation with more developed countries. I cannot help but ask, are these naysayers correct? As the title suggests, let's go down memory lane. In 1960, Singapore had 1.6% of its population above the age of 65 years. At that time, the percentage of Ghana's population above that age was 2.96%. This meant Ghana's health system ensured more longevity for our population compared with Singapore. By 1970, Singapore had increased this percentage to 3.28% and was at par with Ghana. Today, the percentage of Singapore's population above the age of 65 years is 15.12%, while Ghana's is 3.55%. How did Singapore succeed where Ghana has failed so badly? The answer lies in the country aspiring for the very best amongst all nations. The competition in all aspects was not between the different political parties, though elections mattered, but with countries that they had no business competing with. To quote Lee Kuan Yew, for a society to be successful, it must maintain a balance between nurturing excellence and encouraging the average to improve. There was no emphasis on those below average. There were no ifs or buts. It was just a quest to be excellent. It is therefore unsurprising that according to Statista, the Health and Health Systems ranking of countries worldwide in 2023, Singapore was ranked first with a health index score of 86.9%. Of the comparator countries, Rwanda had a score of 64.6%, Ghana 63.1%, Sudan 60.5%, and Liberia 48.6%. One similarity I see between the health models of both Rwanda and Singapore is a strong political leadership driving the concept of taking healthcare to the community, which enables those with undiagnosed chronic diseases to be identified early at the community level. This allows for early intervention and better health outcomes. Is this an approach worth exploring? Looking at the health outcome data and the significant advances Rwanda is making, I see them making similar strides. We therefore owe it to ourselves to be the generation that said, enough of the mediocratic organic growth in health outcomes. If not, Just as I stand before you today and paint a pale canvas, the generation after us would have an even worse verdict of our stewardship. To think that Ghanaians had better longevity in 1960 compared to Singapore, but today, comparing the two countries is seen as outrageous, brings me to this conclusion. Leadership models and what good looks like in health. Examining health systems that achieve remarkable health outcomes, such as those of Singapore and Rwanda, unveils a common thread in their approach to identifying and empowering leaders. These exemplary systems stand out for their adept methodologies in leader selection and development. At the core of their success lies a rigorous merit-based system for leader identification and appointment. This involves transparent advertising vacant leadership roles and implementing meticulous processes to discern the most suitable candidates. These leaders operate under performance-based contracts, bound by measurable health outcomes and outcomes that serve as performance benchmarks. These parameters are periodically evaluated by overseeing authorities, fostering a culture of accountability. Central to their effectiveness is the provision of secure tenure of leaders, ensuring stability for medium to long-term planning. These plans are rooted in prevailing health outcomes and encompass ambitious targets aimed at driving sustainable enhancements over time. Through their tenures, these leaders orchestrate the guidance and supervision of subordinate officials, often appointed through a decentralized, merit-driven framework. Notably, even shifts in political leadership fail to necessitate an overhaul of the health leadership, prompting continuity and strategic alignment. Embracing the notion that leadership is cause, everything else is an effect. These health leaders operate with a resolute vision that propels their endeavors forward. So what's the way forward? In conclusion, as we navigate the intricate intersection of Ghana's democracy and public health, a path forward must be charted that aligns our democratic principles with the pursuit of better health outcomes for all our citizens. Our journey from 1993 to present has illuminated the need for a more collaborative and comprehensive approach to leveraging our democratic system to yield dividends in health. A look at our presidential election results since 1993 points to no political party ever winning over 60% of the popular vote cast. A critical analysis will show that each of the two dominant parties who have had the opportunity to govern have between 44 and 46% of the voters as score following. They only win elections when the majority of the remaining 10% opt to side with them. However, in practice, post-election, the winning candidate looks inwards, selecting voices from within his circles while ignoring inputs from anywhere else. The losing party waits its turn, jettisons most of the activities the previous government had initiated. The marginal 10%, who are the kingmakers, go back to sit on the fence whilst observing the winning party govern, only to become disgruntled when the health dividends do not materialize. Did the framers of our Constitution promise us improved health dividends or a comical display of musical chairs? It is crazy that we have consistently ignored the intellectual contribution of over 50% of our population on a partisan basis and expect our health inputs to yield transformational outcomes. How we can believe that the supposed men capable of turning our health fortunes reside in approximately 45% of our voting population defies me. Perhaps the former president was right. we have short memories. We have become averse to obvious statistics that stare us in the face. To think that the leadership of our health system and all teaching hospitals change in line with our electoral cycle is bonkers and sends chills down my spines. We change them as though we are changing those who manage our pit latrines and private toilets. They all change at the end of an election. How can we expect these leaders to plan for medium to long-term health outcomes when they have no guarantee of tenure? The president can wake up tomorrow morning and say he had a bad dream, and then sack the director of the Ghana Health Service. The law allows him to do so. This concept of tying leadership in health to the executive is one we must fight to change with all the muscles if we expect to see health improvement commensurate with our health investments. Leadership at the technocratic level should be based on meritocracy and not political allegiance. We should care less about the political affiliation of our health leaders and more about their competency. As Deng Xiaoping famously said, it doesn't matter if the cat is black or white, as long as it catches mice. To wit, when it comes to health, all that matters is value for money health investments that yield optimal outcomes. That is what pragmatism teaches us. The pursuit of better health outcomes demands a multifaceted approach that transcends mere rhetoric and short-term gains. Instead, it necessitates the establishment of robust processes and frameworks that promote inclusivity, cooperation, and the wise allocation of resources. To achieve this, we must, 1, engage in inclusive conversations. The development of a sustainable health policy should be rooted in conversations that include voices from all levels of society. Inclusivity ensures that the policy framework addresses the diverse needs and challenges faced by different segments of our population. The era when politicians come out with a plan and sell it to us as the solution without understanding what our pain points are must be buried. Our leaders must first listen, think, and then dream. It is only after having a dream should planning commence. Martin Luther King, during the civil rights movement, talked of a dream, not a plan. We cannot aim for the skies if we fail to be utopian. 2, prioritize research and data-driven decision-making. The journey towards better health outcomes must be guided by data and evidence. Rigorous analysis of health indicators, comparison with similar nations, and regular assessment of progress are essential for informed decision-making. Embrace long-term vision. While politicians often seek short-term victories, the dividend of a functioning health system manifests over time. Policymakers must adopt a long-term perspective that prioritizes sustainable improvement in health indicators. 4, focus on prevention and well-being. A true health system lies not only in treating ailments, but in promoting preventative measures and the overall well-being of the populace. Investment in public health education, disease prevention, and healthy lifestyle promotion can lead to sustainable gains in health outcomes. 5, transparency and accountability. Holding political leaders and policymakers accountable for the outcome of health investments is vital. Transparency in resource allocation, performance evaluation, and reporting fosters a culture of responsibility and continuous improvements. As citizens, let's stop accepting tinkering around the edges as improvements. 5, strengthening collaborative efforts. Health challenges are multifaceted and require collaboration between various sectors, including healthcare, education, and social services. Cross-sector partnerships can amplify the impact of health investment and deliver holistic benefits to citizens. 7, continuous learning and adaptation. Policies and strategies should be flexible enough to adapt to changing circumstances, emerging health threats, and technological advancements. A commitment to learning from success and failure ensures constant refinement of health interventions. A good understanding of this could help with addressing one of the main drivers of health worker migration, which has become an existential threat to our health system delivering desirable health benefits. 8, public engagement and advocacy. Citizens play a crucial role in holding government accountable and advocating for their healthcare needs. Active engagement and informed advocacy can push for sustainable investment and improvements in healthcare. As we reflect on the legacy of Ghana's first president, Kwame Nkrumah, his vision for accessible and quality healthcare resonates strongly in our pursuit for better health outcomes. The road ahead is illuminated by the lessons of our past, and is our collective responsibility to ensure Ghana's democracy flourishes not only in politics, but also in delivering tangible dividends in health. Let's embark on this journey with a shared commitment to fostering a nation where the well-being of every Ghanaian is the bedrock of our progress. By enhancing collaborative processes, evidence-based decision-making, and long-lasting policy frameworks, we can leverage our democratic values to achieve transformative improvements in public health. As we move forward, let our actions reflect the aspirations of our democracy, equality, inclusivity, and the well-being of our citizens. We must always remember this quote from George Bernard Shaw: "The reasonable man adapts himself to the world. The unreasonable one persists in trying to adapt the world to himself. Therefore, all progress depends on the unreasonable man." If we want improvements in our health dividends, we need to be unreasonable and become more demanding of our elected political office holders. It is too dangerous to sit on the fence or be a praise singer. Daddy, as I retire to my seat, I hope I have been candid with my views and never held back. It would be disingenuous to your memory if I failed in that endeavor. If I've kept charge to what your advice would have been, I can only say thank you. Our regards to Mommy. You've both left your mark. May your non-conformist soul rest. Ladies and gentlemen, thanks for the audience. Thank you.
Thank you very much, Kwame. Please, let's put it together again for Kwame. Daddy definitely will be proud of this one. Some very difficult truths which are necessary to be told. That compared to similar countries over the period, we end up spending a lot more on health, but delivering a lot less to our people. And that has persisted over the entire duration of our Fourth Republic, make it particularly difficult. More so when juxtaposed against the fact that we've seen both major political parties govern this year in nearly equal measure. I mean, God has a sense of humor. So both have virtually the same number of years running this country. And so if there are challenges, it is only fair to look up to leadership and to ask all those difficult questions and to ask ourselves what can be done about our health. Because without health, the nation perishes. The nation becomes like a bird without wings that cannot fly. And we believe that one of the key dividends of democracy is our wellness. Indeed, I would at this juncture encourage everybody to move forward a little bit. Our colleagues have asked for it. Even as I go on to invite the co-presenters for today. And first off, I would want to acknowledge everybody here. Repeat that this program is the collaboration between an amalgam of professional bodies and Joy News, and it's the second in a series, and we expect to have a lot more, speaking about matters pertinent to this country, particularly related to our democratic journey and how we can even make it better for the millions of Ghanaians who look up to us. May I plead that you move forward a bit, please? Thank you very much. Thank you very much. Thank you very much. Thank you very much. So even as we sit, I would want to introduce Dr. Priscilla Chumesi Bafo. Doc, could you please stand and come up? So Doc holds a PhD in Econs from the School of Econs, University of Nottingham, and she has a BA and an MPhil from University of Ghana. She's currently a senior lecturer at the Department of Economics, University of Ghana. She's affiliated to Credit School of Economics, University of Nottingham since 2010. And Doc has researched broadly, widely. Her topics of interest include labor markets, gender and inequality, international trade and development econs. She's authored several publications in these areas. And Priscilla has collaborated and worked on projects with international organizations, and there are lots here. Of course, she's a very active contributor to national discussions on the Ghanaian economy, and she's been a regular panelist on the BBC Radio Business Matters program. Doc, please come up stage. Please put it together for Doc. Doc, your chair.
Thank you.
Joining Doc here is William Delali Ofori. William is a pharmacist. He is deep in management finance. He has an MBA, and is pretty much a recognizable face in the pharmaceutical and healthcare industry in Ghana. Doc has 30 years experience in the multinational pharmaceutical space. Over 18 of these have been at the very senior country and trans-regional roles. He served as a regional director for West Africa for AstraZeneca and was a member of the Sahara Africa senior leadership team in the same organization before leaving in October 2020 to start his own consultancy. William, I'm making a doctor. William comes with very rich insights and experience in many aspects of health, pharmacy, the industry. He's looked at policy, he's done regulation, he's done corporate governance and management, and he's done it across Sub-Sahara Africa. He's consulted with a kind of McKinsey and many others. Could you please, at this moment, join us, Mr. William Delali Ofori. Getting ready for this presentation and looking through the data, one of the data points that was particularly intriguing was the SDG 3 that speaks to good health and well-being. And if you go to the website, the point is made, and the point that our main speaker very eloquently articulated, made of the fact that Ghana is facing numerous health challenges. Indeed, the word is major health challenges. But it also indicates that we are improving, albeit albeit in a very moderate way. And indeed, our main speaker also alluded to that. But what jumped at me is that if you look at all the metrics, and there are about a dozen or so of them, almost all of them are not trending in the right direction. There are only two which are positive, which indicates progress, clear progress. One is new HIV infections, and the other is surviving infants who receive 2 WHO recommended vaccines, the percentage. Now the challenge is that earlier this year we all heard the story about the vaccines, and the other worrying matter is that a recent report that came out, I believe 2 or so weeks ago, indicated that for the first time in a long while, HIV is trending very wrongly in Ghana. So, as if to say the only 2 places where we're supposed to be doing well, even there we have significant challenges. Which brings me to my panelists who are going to talk to us and share their opinions on this very difficult but essential matter of our health, particularly as a dividend of our democracy. Priscilla, ladies first. So you talk to us first, your audience. Thank you.
Thank you. Do I have?
Yes, please. Or you can sit. I mean,
No,
feel free. Yeah.
Thank you. Ladies and gentlemen, good evening. Let me take this opportunity to thank the organizers of this evening's public lecture for the confidence reposed in me, for me to share my thoughts on the presentation of an older brother. I will try not to be intimidated, but to be objective. Kwame does a great job in his presentation by walking the audience through a journey down memory lane since 1993 to date, but by carefully refreshing the memories of the older generation and perhaps inform the younger generation of the holistic healthcare vision of Dr. Kwame Nkrumah, the first president of this nation. He then goes ahead to ask a number of questions which pertains to the tenets of democracy in the area of healthcare, with specific emphasis on outcomes, which he calls democratic dividends, healthcare dividends, under the Fourth Republic. The outcomes he uses 6 outcomes effectively, 5. Life expectancy at birth, maternal mortality, infant mortality, under 5 mortality, and survival to the age of 65. So he compares the trajectory of these indicators with that of a selected African countries, and the countries are Rwanda, Sudan, and Liberia. So an objective question one would ask is, why pick these specific countries? I believe on the sidelines, the conversation had been, these countries have gone through civil wars, so they have had to come from a very deep place, whereas Ghana has not gone through anything like that. And so another criticism that comes up straight from the presentation really is that if you just pick indicators like maternal mortality, life expectancy at birth, and then you compare Ghana in 1993, and then you look at the figures in 2000 or 2020, and say that the percentage increases in these countries are higher than the percentage increases in that of Ghana, it's a bit problematic in terms of methods, because if you are coming from a lower base, then your percentage increase would be higher than someone who is coming from a higher base. So in that sense, it's more like it is easier to get to the top, but maintaining the top position or being there requires a lot more work. So he steps back a bit to compare Ghana in 1960, to get away from that whole box of criticism around just percentage increases, he looks at Ghana in 1960 to Singapore at the time, a country at the time where Ghana essentially had an upper hand in terms of longevity, because Ghana had a higher percentage of persons above 65 in Ghana than in Senegal. So to me, the most compelling aspects of all this is the fact that Ghana spends significantly more on health per citizen than all the selected 3 countries he looked at. Essentially, Ghana spends, the health expenditure per capita is $84.98, compared to significantly lower figures reported for the 3 other countries. So, as an economist, I ask a number of questions, but we also note that this funding comes from a place, the national budget. And historically, Ghana has persistently run budget deficits, which are financed through borrowing. I am sure nobody here is stranger to the word domestic debt exchange. Essentially, the debt situation is because of the significant shortfalls between revenue and expenditure. So as the country struggles to deal with issues of revenue mobilization, which is persistent when you go through the data, particularly with emphasis on the Fourth Republic, one would expect that we'll place a lot more emphasis on prudent expenditure management. Prudent expenditure by emphasizing on good value for money. And from the data in the healthcare sector as presented, it is quite evident that Ghana spends more on health with far less returns in terms of health outcomes, where these health outcomes have been beautifully articulated. So I am not surprised that the health outcomes that we see are not great, and at best it appears we have been quite sluggish in the growth whilst others are growing faster in the right direction. Why? Because we know that development is a continuous process, and development which must translate into high incomes for citizens, good education, better health outcomes, and social security for all, it's a continuous process. But when you track the growth trajectory of this country, it has been quite checkered. So there is the need under this democratic dispensation to look at the sources of vulnerability. What happens to the productive sectors of this economy that makes the economy struggles to grow in the right direction, to yield some of these dividends, including healthcare outcomes. The health of every nation is in no doubt its greatest assets. A healthy population reflects in a healthy labor force with important implications for productivity and decent work. Healthcare, just like education, is a human capital investment because it translates directly into the ability of the population to generate wealth. Indeed, in the discussions on development indicators, the literature has now moved on from income to place a lot more emphasis on other indicators of development, such as health and education, because it is evident that income alone is not enough. It's a necessary condition, but it's not a sufficient condition for development. So in the development discourse, the emphasis now is on multi-dimensional measures of development. And here we can talk of a typical example of the Human Development Index. So I sort of checked on the Human Development Index, which is also a composite index which takes into account income, education, and health. I know that the emphasis for this evening is on health, but when you take a composite index like the HDI, you find that essentially, although Ghana has a slightly upper hand over the comparator African countries, Rwanda, Liberia, and Sudan, it is significantly below that of Singapore, because the figure for 2022, Ghana's HDI is 0.63, Singapore is 0.94. And this is a country that we rubbed shoulders with years ago, as of 1960. So I would not want to belabor the points in concluding on my remarks on the presentation. A number of burgeoning questions come out from the presentation for me. One of them is that if Ghana is spending more with a higher health expenditure per capita, why are the outcomes lower than the comparator countries? Is the country spending on what is at the core of healthcare in the country, or something else in the name of healthcare expenditure? So in this instance, the emphasis should be on efficiency in healthcare expenditure. Does the country spend on particularly expensive aspects of healthcare systems compared to the comparator countries? Does the country unduly focus on, for example, hard infrastructure to create access, while not necessarily focusing on the quality of healthcare that is available to the citizens? What is the role of technology in this day and age of technological advancements? How is the country taking advantage of technology to bridge the gap between access and quality, whilst introducing efficiency in healthcare expenditure? I believe these and many more are the questions that beg to be answered, and the lecturer this evening has beautifully articulated them. I'll end my remarks here. Thank you.
Thank you very much, Doc. Mr. Ofori, the podium.
Diseases, diabetes, stroke, heart attack, cancer, name it. The whole unit is less than 6 professionals, maybe half of the number I'm giving you. Since 2011, they have depended on donor funding and partner funding. The last official funding they had from all the per capita spend you're talking about was 200 Ghana cedis. So how does this translate into outcome? And how does that affect our health? Okay, so he talked about average life expectancy, or the average Ghanaian worker would live till 64. You're paying SNIT, Social Security, you're investing in pension. But what I'm hearing is that the average pensioner will enjoy his pension for only 4 years, the average, and die. It means the average civil servant will die 4 years after retirement. Now, that is sad, but that's the reality. So the Department of Non-Communicable Diseases, or the unit of the Ministry of Health, would oversee 6,400 CHIPS compound. And we have, arguably, one of the best in terms of the system setup of primary care, basic level in healthcare. That's the setup. Thanks to the robust leadership from Ghana Health Service. These 6,400 CHIPS compounds are all over the country. And we have the best tier system, one of the best tier systems in terms of CHIPS compound to, primary healthcare facilities, etc. Okay, so we have 6,400 CHIPS compound and 1,200 health centers. But to prevent the dangerous outcome we're seeing, we need to train the staff. We need to equip the staff. We need funding. The unit responsible for driving that hasn't got money from the per capita spend. Okay? So to prevent one of the biggest cancers amongst women, which is breast cancer, all you need is to train the nurses at the CHIPS compound and the 1,200 primary health care centers to use their hands and their eyes. Basic breast examination. But we don't have money to do that. What you need to prevent cervical cancer is a 20 cedi test. The more complicated test, which is the VIA is 20 cedis. The more complicated test, the pap smear, is 120 cedis. But we can't do that even at the basic health centers. And so in 2020, 2,200 confirmed cervical cancer cases, over 60% died. That is startling. That is sad. That's irresponsible. Now, if you detect cervical cancer early, all you need is a thermal coagulator, and you will treat it. If we sold one Toyota four-wheel drive V8 for somebody high up there, we will buy 100 thermal coagulators, put in 1/3 of all the districts in Ghana, and improve outcome in cervical cancer. So why can't we do these little things? That's my point. I don't know whether it makes Kwame sad or it makes the economists relook at the figures of where we're spending our money. But it is sad. So I talked about if you were in crisis, and yesterday I was talking to a couple of friends at a funeral, and always at funerals I reflect on life. And I was talking about, so we're all at the funeral here, and a few of you medical experts are at the funeral, who's looking after people? Because there was a time when I had an urgent call to find a neurologist. Now, the neurologists look, amongst other things, they take care of all the stroke cases. And two of my friend neurologists were away in Nigeria teaching. One was at a funeral of his father. A couple of them were on vacation, and a couple were out of town or because they're in Kumasi or wherever. Now, there are less than 12 neurologists for the 15+ million adults or 32 million population. There are less than 12. I'm not just talking neurologists. Interventional cardiologists, they are less than 12. Endocrinologists, they are less than 12. Nephrologists, they are less than 12. Medical oncologists, they are less than 12. That is scary. In the country. I'm sure there are more in New York City or New York State who are Ghanaians. Trauma specialists, same. Of course, we've made some advancements because 2.5 decades ago, you couldn't count female gynecologists on one hand in Ghana. But we've made advances. Family physicians, thankfully, for those who have the insight to put up places like the College of Physicians and Surgeons, we have trained a number of family physicians and other specialties. I remember when you could count the number of doctor anesthetists on 2 hands in the entire country. So when they put you to sleep, it was nurse anesthetists. And they didn't have enough to have a theater assessment. So we've come some way, but have we come far enough to change the outcomes? Because health is wealth. The average life expectancy in Kenya, Uganda, and Tanzania have overtaken Ghana. And in Kenya, wait a minute. So once I was at a very nice hospital. They have good facilities. Somebody had been rushed from the mining site all the way to Accra. And so I asked the driver at the entrance of the accident emergency, how long have you been driving? And he said, well, a few hours. And there was a Kenyan person I was with who said that in Kenya, even from the middle of Afram Plains, an air ambulance will lift you. This is not Singapore, okay? This is Kenya. An air ambulance will lift you and take you to Kolebu 37, University of Ghana Medical Center or whatever. The system works, and their per capita spend on healthcare is less than ours. So again, how do we focus on the other indicators aside the mortality and the survival birth rate? I'd like us to take a second look at the quality of care in terms of service delivery. What is your patient experience after spending all this per capita when you drive into a hospital, when you're rushed into a hospital? What is the quality of life with respect to healthcare delivery? If you are ill, if you have a chronic condition, how are you looked after? What is the access to healthcare? And access to healthcare is not access to the buildings, because some of the buildings, nothing happens there. Access to healthcare means a facility, trained personnel, processes and systems working to ensure that we will do everything medically possible to keep every patient alive, if it's possible. That's where we should be measuring where we're spending our money. Preventative health. What are the lifestyle indicators? What are the disease outcomes? What is the probability of somebody who has a stroke or a heart attack surviving in Ghana versus that same person surviving in Kenya, versus that same person surviving in Rwanda, and then versus that same person surviving in where we want to benchmark ourselves in the developed world? So I used to argue with people that say the French medical system is much better than the American medical system, but the American medical system, at the cutting edge, if you have money, yes, it can do anything, it can do magic. But the average person, whether a cabinet minister or a laborer who gets pregnant day one in France, is assured of excellent medical care till delivery. Now, if you take the level of taxation for those who pay taxes here, you're being taxed the same as the level of taxation in France, if you're in the higher bracket. So, is this quality of care possible? Yes, because I have known small clinics here taking care of mother and child, maternal and child health, who have in 10 years delivered maybe close to 1,000 babies, and touch wood, haven't lost one baby. And what does it take? Simple things, simple monitors, commitment of the team, monitoring, constant improvement, keeping track of your data and quality of care, setting standards in procedures. That's where we need to go to. It's what does good look like? And how will we get there? First of all, I think that in terms of disparity in service delivery, we should come to a point where whether you're rich or poor, you can be guaranteed a certain level of service.
I need to do the difficult one of coming in here.
Okay.
But maybe you do a wrap,
I'll
and
do
then
a
there'll
wrap
be
up.
other opportunities
Okay.
here.
So again, just to wrap up, I think that in April, the healthcare minister bemoaned the fact that, I don't know, I'm hoping that the journalist got it wrong, but he said that the health insurance system wasn't working. I don't know why, because he went to Rich Hospital and had to pay out of pocket, but he had his health insurance card. No bed syndrome is a matter of the processes not working. In short, where do we need to get to? We need to, and you can quote me on this, we need to democratize healthcare to the extent that the democracy cannot adversely affect the healthcare outcomes. We need to democratize healthcare to the extent that democracy cannot adversely affect healthcare outcomes. We need to improve our human capital and ensure that a system is functional enough not to offer wide disparities in healthcare delivery. The system should ensure that democracy is forced to deliver the desired outcomes to the people and be accountable for every cedi and dollar spent to improve healthcare outcomes, reduce the disease burden, improve the quality of care, and improve access to care and quality to life. COVID-19 has taught us that, yes, we can. Ghana performed amongst the very best in the world with the same healthcare professionals we have today. So, under the duress of COVID, we proved that, yes, for every dollar spent, Ghana can deliver the desired outcomes. Can we translate that to the rest of healthcare delivery? Thank you.